Okay, good afternoon, dear gentlemen and colleagues. I think it is very great honor for me to invite all of you to join today's session. And first, I want to welcome Dr. Dabas to join our session, and as well as Professor Zeng Yong and Professor Zhang Ran, Professor Li Chengguang, Professor I think that Professor Chen Nanhu to join our session. We can see that the topic of our session for today, we focus on the mechanical machine circulation with high-risk PCI patients. I think following our schedule of the session, maybe Professor Dabas, you want to say something for our session and to introduce the first speaker. Thank you.
Okay, thank you, and good afternoon, colleagues, and welcome to this session on mechanical circulatory support and acute coronary syndrome. Today's program will focus on the latest evidence regarding Impella, ECMO, and contemporary mechanical circulatory support in cardiogenic shock and high-risk PCI. It's my pleasure to invite our first speaker, Dr. Kuhlman Lee, to present the DANGER trial and beyond. Impella support in infarct-related cardiogenic shock. Dr. Lee, the floor is yours. Thank you.
Thank you. And can you hear voice, please? Okay.
Yes,
So,
we can hear you.
Okay. So, and I would like to talk about the DANGER trial and beyond Impella support in infarct-related cardiogenic shock and evidence and real-world application. I have nothing to disclose. So, as a background, cardiogenic shock complicates approximately 5 to 10% of AMI cases and is associated with high mortality rate ranging from 30 to 50%. Cardiogenic shock due to the ACS was more than 30,000 patients annually in the United States and Europe. In Japan, cardiogenic shock required a mechanical circulatory system worth more than 14,000 annually, and 80% of cardiogenic shocks were ACS, as you can see. So, and at first, and I would like to present a case of STEMI cardiogenic shock of 70s male. He presented our hospital with STEMI, then he underwent emergency coronary intervention, as you can see, and the ST elevation in the inferior lead. So emergency angiography revealed that the right coronary artery distal to subtotal and the ready mid region shows a CTO. So, and during the coronary angiography, he was in progressive cardiogenic shock, and then we performed the implant and Impella and for STEMI cardiogenic shock before the procedure. Then, and under the Impella support, PCI was successfully performed and the stent was implanted, and as you can see, and coronary flow was recovering. And then the next day, we performed the PCI for the LAD CTO and they successfully performed. And the final angiogram is, as you can see, and LAD was and not so good flow, but and good enough. So the summary of this case was an Impella was show this slide, and Impella was inserted before emergent PCI for RCA. On the next day, PCI for LRD CTO was successfully done, and Impera was withdrawn on day 5, and he was discharged from the hospital on day 27, and he was doing well so far. So, and that is a very representative case of danger shock in eligible patient. So, as you can see, danger shock trial was international randomized trial, and patient with or without an Impera, with and standard and versus standard care. This study was conducted in Denmark, Germany, and the UK investigators, and 355 patients were divided into the two groups, Impera plus standard care and the standard care alone. So the danger shock trial has several inclusion-exclusion criteria, and the primary endpoint, secondary endpoint, blah, blah, blah. So then the primary endpoint was death from any cause at 180 days, and the secondary endpoint as shown here, and the composite safety endpoint was severe bleeding, ischemia, hemorrhages, and so on. So inclusion criteria is relatively complicated, but in main inclusion criteria is shown here, and in patients with STEMI, less than 36 hours duration, with cardiogenic shock in less than 24 hours duration. And in this trial, definition of cardiogenic shock was hypotension and hyperperfusion, defined as atrial lactate more than 2.5 millimole per liter, and LVEF less than 45%. And STEMI, where shock develops during or up to 12 hours after revascularization. And the main exclusion criteria was shown here, and main excluded patients was ECMO on randomization. So results are shown here, and in danger shock trial primary endpoint, 180 days mortality was significantly lower in the Impera group than versus standard care alone group. P-value was 0.04, as you can see. Also, secondary endpoint was significantly lower in the Impera group than standard care alone group. So, and they concluded that among patients with STEMI associated with cardiogenic shock, mortality was lower with the use of an Impera in addition to standard care than with standard care alone. So, and it's okay, but there are several issues to discuss in this trial. And in case 1, and that is a very representative case. So Impera is very suitable, and he was also doing well. However, there are some clinical questions in terms of real-world application. And one is the Impera for patients with ECMO, and patient with Impera for non-STEMI with cardiogenic shock. The first is Impera for patients with ECMO. In case 2 was 70th male, STEMI cardiogenic shock with ECMO Impera, so-called ECPERA. And he presented the emergency room due to chest pain, and he progressed to the cardiogenic shock and PA on EKG. So, and VA ECMO was inserted at ER. And as you can see, his EKG showed a ST elevation, and he went to the cath lab. And as you can see, the proximal was subtotal, and at first we inserted an Impera before PCI, so-called ECPERA. So under the Impera support, emergency PCI was successfully performed, and the final coronary flow was TIMI3, and as you can see, and the angiogram showed good. And this is a summary of case with STEMI cardiogenic shock under the ECMO plus Impera. And the Impera was inserted before emergency PCI, and the PCI was successfully done. and VA ECMO and Impera were withdrawn on day 3 and day 6 respectively, and he was discharged from the hospital on day 27, and also he was doing well. This is a successful case of the so-called ECPERA. So, and as you can see in this case too, in danger shock trial, patients with ECPERA was looks good, but in danger shock trial, patients with ECMO before randomization were excluded. So this is not danger shock eligible patient. Although there are no clear evidence of Impera for patients with VA ECMO to date, patients requiring both VA ECMO and Impera, so-called ECPERA support, are not unusual in real-world clinical setting. So, and recently, Japanese investigators published the data of the registry data in Japan. So-called, and the registry name was JP-BAD registry. And they assessed the danger shock eligible and ineligible acute myocardial infarction-related cardiogenic shock patients in nationwide Japanese registry. As you can see, cardiogenic shock patients was only danger shock eligible cardiogenic patients was only 35%. And in registry data, they investigated the VA ECMO first patient and Impera first patient. So as you can see, patients with ECMO first followed by Impera showed 52.1% of 30 days mortality, which was similar to patient with standard care group in the danger shock trial. Very high. So, and Impera for patients with ECMO is still controversial. So the secondary Impera for non-STEMI patient with cardiogenic shock was discussed. Okay, so this is a case 3 non-STEMI cardiogenic patient. He presented to the emergency room with chest pain, and EKG showed BT and progressed to BF. And after LOSC, he underwent emergency coronary intervention. So as you can see, an emergency coronary angiogram shows the left main very tight stenosis. So I was also revealed that thrombus or the left main trunk, and emergency PCI was performed into the left main artery, and the stent was successfully implanted. And as you can see, final angiogram shows looks good. After PCR, we inserted IABP due to post-PCR coronary flow was not good, and he was not good condition, requiring the inotropic agent. But on ICU, 10 hours after PCI, hypoperfusion did not improve, so lactate was 3.4 millimole per liter. Therefore, we upgraded MCS from IABP to Impera. So Impera was withdrawn on day 7, and he was discharged from the hospital on day 30. So Impera was very effective in this case. So summary of this case was shown here. The patient with non-STEMI attributable to left main cardiac lesion was treated with DEF, and IABP was inserted after PCI. However, hypoperfusion did not improve after PCI, and we upgraded to Impera. And he recovered after Impera and discharged from day 30. So registry data in Japanese NSTEMI cardiogenic shock patients was shown here. So about 13.4% was non-STEMI patient. So, and this is not ineligible for the danger shock trial. However, as you can see, patients with non-STEMI cardiogenic shock patients showed a similar 30-day all-cause mortality compared to the danger shock eligible STEMI cardiogenic shock patient, and 33.3% versus 37.6%. So, and and as you can see, clinical question in terms of real-world application, Impera for patients with ECMO is still controversial. However, and Impera for non-STEMI with cardiogenic shock was as effective as similar to STEMI cardiogenic shock patients, but there and still more data is needed. So finally, and I would like to present the case of the 15th male STEMI cardiogenic shock with ECMO plus Impera. As you can see, and ST elevation in the inferior lead, and he showed the VF at the ER, and VA ECMO was inserted before the PCI, and he went to the cath lab under the VA ECMO support. So as you can see, right coronary proximal RCA was occluded, and however, other left main and LAD and circumflex was not so suitable for PCI. So we performed the PCI for RCA, and PCI was successfully performed, and Impera was also inserted. So, and so far it's good. But however, after successful PCI, he went back to ICU, and his vital sign was stable and the extra support. But on day 2, mydriasis was found, and brain CT showed severe cerebral hemorrhage. So this is a very severe adverse event. So according to the danger shock trial, adverse events were significantly higher in the Impera group than standard care group, 24% versus 42%. So, and in detail, adverse events show the severe bleeding, limb ischemia, renal replacement therapy, and sepsis. In the Japanese registry data, also major bleeding was 26.6% in all overall Impera group, Impera patient, and this was similar to the danger shock trial. So this is the final slide. So, and the evidence of danger shock trial tells us that in patients with pure semi-cardiogenic shock, Impera is a promising device in terms of better all-cause deaths. So in real-world settings, registry data tells us that in patients with ECMO support before Impera insertion, it is still controversial whether Impera can improve outcome or not. Impera might have similar effectiveness for patients with non-STEMI cardiogenic patients. Adverse events, bleeding, limb ischemia, etc., are still important issues to be improved. Therefore, the studies are needed to resolve aforementioned issues. So thank you for your attention.
Thank you.
Thank you.
Okay, thank you, Professor Chu Min. I think this is a wonderful presentation. And I think let's follow the schedule. Is there any question from the panelists that we can share some topic about today's topic? Okay, I think if we do not have anything to discuss, we can discuss together at the end of today's session. Okay, following the schedule, maybe I want to introduce the next speaker, Professor Li Chengguang, to give us a talk with the topic of mechanical circulatory support for elective high-risk PCI ECMO vs Impella. Professor Li Chengguang, I think, is a very famous PCI surgeon in China from Fudan University, Zhongshan Hospital. Okay, I will give the time to Professor Li Chengguang to give the talk for today.
Okay, thanks for the invitation and thanks for Professor Cao. And I will to share my topic. My topic is about the mechanical circulatory support in elective high risk PCI. And today we will to discuss the device about the ECMO versus impeller, when to support and whom to support. So before this, we can imagine for now the high risk PCI is becoming more and more popular, and you can imagine you have accepted a complex and heart failure and multi-vessel non-surgical patient for PCI. So do you want to support preventively and with what? So the first question, which patients derive net benefit from the preventively MCS before the elective PCI? And the second question is about which we want to choose, the impeller or the ECMO. So also we should to think what do the prospect 2, the basics 1 and the chief basics 3, and also other clinical trials tell us. So for now, we could see the high-risk PCI population are growing very, very quickly. The advanced age and with the CKD and also with the heart failure, and we can see whether in the Europe or in the Asia and also in the America, we could see the MCS uptake is rising very quickly. But for now, we have little evidence about this MCS area. So we could see the large RCT in elective high-risk PCI in this 10 years, the basic 1, the prospect 2, and also the chief basics non-match is primary endpoint. So we should to talk about this topic. Before we talk about this topic, we can imagine we have a patient and elder and with CKD and diabetes and also prior CVA with residual mild right hemipares and also peripheral arterial disease, and also for this patient the syntax score was 36, and also we want to do the complete revascularization by PCI. So what we will choose, the fourth choice is about the IBP on standby. We just to proceed unsupported, and the second we would do the preventively impeller CP, and also the third we will do the preventively with ECMO, and also the fourth we will choose the elective IBP. So which strategy we will choose? So before this answer, and maybe we can talk about this topic before this answer. And for now, I think maybe we have many definition about the high risk PCI and how to interpret the high risk. I think maybe it will across the 3 level. The fourth level is the patient level. We could see the patient with a severe left ventricular dysfunction, the advanced age and fertility and CKD and prior stroke or peripheral arterial disease and so on. The second level is about the lesion. For example, the left main, the bifurcation, the CTO, and also the multivessel disease. And the third level is about hemodynamics. It's about maybe the baseline low cardiac index and also the low cardiac power output and so on. So I think maybe the high risk will include many magnitude. So if we look back into the post trials, we could see the landmark trials how to define the high risk. We could see most of the trials about the severe left dysfunction and also the complex extensive lesions in non-surgical patients. And also maybe this is a population every trial is trying to describe whether the basic 1, the prospect 2, prospect 3, and also the ongoing prospect 4. So maybe in these landmark trials, we could see the same picture about the high risk. So for the high risk PCI, what are we going to buy? Of course, during the PCI of a large ischemic batch, the transit balloon inflations and also the no reflow or ventricular ischemia and can precipitate a abrupt hemodynamic collapse. Of course, the MSCS, we expect it will to maintain the systematic perfusion and also the protect end organ flow and also permit deliberate complete revascularization. And also for the operator, we want to longer balloon inflation and also we want the deliberate rotational economy and also we want to do the single session multivessel revascularization when the stain is undescribable. And also we want to provide a bailout margin if the case describe concepts. But we should see the every MCS device introduce new failure models. For example, the large bore arterial access. For example, the bleeding, the limb ischemia, and also the stroke. Also the ECMO will meet the offload paradox and also the cost. We should also to consider it. So net benefit only when hemodynamic benefit exceeds these harms, we will choose the MCS device. So the second part we will talk about the device engineer and hemodynamics. It's about the impeller CP, impeller, and VA ECMO, and also as well as the IBP. So for the transvalvular microaxial for pumps, we could see all impeller devices actively upload the LV, decrease the LV volume, PCWP, and also the myocardium oxygen demand. And also it requires an obstructive aortic valve, absence of the left ventricular thrombus, and also the adequate iliofemoral access. So this is about the impeller. So we could see the impeller will unload the LV, will reducing the wall stress and increasing the coronary perfusion while providing partial system flow. It doesn't support RV and doesn't oxygenate. So this is the weakness of the impeller. For the V ECMO, we could see we are very familiar. It will give us the full biventricular system support. It will give us the oxygenation and removal of the CO2, and also it will control the temperature, and it's independent of every contractility. But for the V ECMO, so we also met the paradox of the afterload. The full circulatory rescue at the hemodynamic price, it will the retrograde arterial will return the increased LV upload precisely when the LV is weakest. So we could see for the ECMO, we could see the ECMO will become failure when the LV distension and also the north-south syndrome and also the limb ischemia. So this is the weakness of the EA ECMO. So if we look back into the impeller CP, IBP, and the VA ECMO, we could see the four devices have four physiologies. So the impeller unloads a struggling left ventricular, and the VA ECMO will replace a failing circulation. They solve different problems, so maybe they have some overlap, but essentially they will be solve different questions for the high risk PCI patients. So if we look back into the landmark evidence, for now we have three important RCTs, and the fourth we could see the Prosperity 2. It's about the only RCT of the hemodynamic support strategy versus IBP in elective high risk PCI. The primary endpoint is negative. We could see 35.1 versus 40.1% for the IBP. But if we extend the follow-up to the 90 days, we could see the final event was about the 40 versus 51, and the P was equal to 0.023, and the signal that supported the FDA HR PCI labeling. So if we look back into this trial, we could see the learning curve conformed on sub analysis. The early sites did worse, so maybe the learning curve it will do harm to the effect of the impeller. So this is a 90-day analysis under the Precipitate 2-3 registry. We could see this is a 90-day analysis and it advanced the labeling of the impeller. But for the Precipitate 3, we could see they compare more than 500 Precipitate 2 eligible subset with the historical Precipitate 2 ITT cohort using the PSM analysis. We could see from here the contemporary impeller HR PCI outcomes appear better than a decade ago. It will be driven by operator experience and smaller bore access strategies and also the closure innovations, but no competitor arm. So this is the limitation of this trial. And also we could see the elective IBP in high risk PCI, the basic one, shipped enduring 30-day windows can capture MCS benefit. The same interpretive problem will hang over every subsequent of the high risk PCI RCT, and we could see here the IBP was 15 and also the control was 16, and the long-term follow-up is about the 27.8 versus 38.7, and also the P was significantly positive. So we could see the later mortality benefit remain hypothesis generating. So this is about the IBP, and also we could see the Chi basics 3 is about the microaxial LV unloading in HRPCI, and the number trends numerically favoring the standard care, and also we could see the macro palm group will growing in the mortality. So the attitude is about a more selective approach to the use of MCS in high-risk PCI. So we particularly in the absence of clear hemodynamic instability. So for this trial, we could see maybe the MCS we should to choose the proper population and use the proper devices. So if we look at the numbers behind the signal, we could see the routine LV unloading with a maxoaxial palm in stabilized elective HR PCI didn't rescue major events and was associated with excess CV mortality. And the first perspective RCT of ECMO in elective high-risk PCI, we could see it's about this. The first RCT is in China in Lanzhou by Professor Bai, and we could see none of the ECMO patients had intraprocedural hemodynamic collapse, but in the controls, 7 of 6 will meet the collapse, and the 1 year MACE there is no difference. So in the control arm, we could see about nearly 20% of the patients will use a bailout ECMO. So we could see the ECMO will prevent intra-procedural collapse, but the later MACE benefit will not demonstrated. Maybe the reason is about the bailout ECMO. So we could see the in-hospital benefit was very obvious. So it's also some the observational experience, but not so many RCT. But if we compare with the impeller with the ECMO for now, there is no head-to-head RCT in elective high-risk PCI. So it's about a small population. And for now, we could see the Impella versus ECMO choice mirror the failure model you are trying to prevent. So if the patient you will match the predominant left ventricular failure. So maybe with acceptable right ventricular function, maybe we could choose the impeller. But if the patient is about biventricular or respiratory compress, we will use the VECMO. So for now, maybe no RCT has shown the routine preventively MCS improve the primary endpoint in high-risk PCI. The CHIP basic 3 raises the possibility of night harm from the routine myoaxial LV unloading in stable HR PCI. So also the preventive ECMO prevents the intraprocedural collapse, but later benefit will not shown. And also the ECMO and the impeller are not interchangeable. The choice mirrors the failure model you are preventing. Also, we should also consider about the complication. So if we look back into the impeller, we could see most of the complication will be driven by the 14 French access. And also the ECMO is about the large catheter and also the systematic anticoagulation and also the biventricular stakes. So if we try to describe a side-by-side profile, maybe the different devices will to get the different taxes. The right question is about which specific harm is acceptable for these specific patients. Note which device is safe overall. So also the health economics, we could see the routine impeller for HRPCI becomes not only clinically unjustified, but economically unjustified. It will add the cost with no offsetting benefit in stable patients. So in the future, we could see the guideline all say the same thing. We should to select the patients, also select the heart team, experience center, and also the CHIP basics 3 will likely tighten the language further. And also in the next 2 years, we will have more clinical trials about the PRESPECT 4 and also the multi-center validation of preventively ECMO, and maybe we will expect the results of these 2 trials. So for now, maybe we have several questions. The first is about should this patient have the PCI at all, and also the second is instability likely or already present. The third is about which failure model dominate, and also the fourth is about can we get the access, and also the last is about does the center have the volume. So if we look back and also consider all of this question, we should see this is the algorithm maybe in the future. The default in the stable arch PCI patient is unsupported PCI with IBP or MCS on standby. But if the hemodynamic is not so good, so maybe we will choose the right devices. But the different devices will use the different scenarios. For example, the IBP for standby or bailout in mostly stable cases. The impeller is about the isolated left main failure with adequate arch ventricular or oxygenation. And also the VECMO is about biventricular respiratory and marginal MAP. So finally, maybe we could see the HRPCI is not diagnosis, it's a definition. And also the 3 RCT, all of them didn't match the primary endpoint. The CHIP basic 3 is a real signal, and the ECMO will prevent the collapse of the circulatory, but not late events. And also the device is not the interchangeable. Maybe they will be used in different scenarios. And also the when precedes who. So we should choose a select time, select population, and I think for finally we will benefit for the patients. So this is about the topic. Thank you for your attention.
Okay, thank you, Professor Chen Guang. And I think this topic covers the most of the very important things that when using the mechanical support system, for example, the selection of the device, the time when to use, and what kind of a target patient to apply. Due to the time issue, I think we will keep the discussion later. Okay, I will give the host to Professor Zhang Ran to introduce the next speaker. Okay. Or Professor Chen, I think Professor Chen Nanhu is online, or maybe Professor Chen Nanhu will introduce the next speaker. Okay.
Okay. Now, please join. Now, please join me in welcome our next speaker, Professor Cao Yang, a chief physician at the first affiliated hospital of Harbin Medical University. Today, he will be sharing the latest updates on the topic mechanical circulatory support in elective high-risk PCI update in 2026. Please give a welcome to Professor Cao Yang.
Okay, thank you for the introduction of Dr. Chen, and good afternoon, colleagues and professors. I'm privileged to join this session. I'm Dr. Cao from the first affiliated hospital of Harbin Medical University. According to the schedule of this session, I'm going to share the topic of mechanical circulatory support update information into 2026. We will cover the latest trials, guideline updates, and device selection, and etc. Okay, we are going to share from these 6 views. First, mechanical circulatory support system in high-risk PCI patient. I think PCI procedures, the number and quality is increasing day by day, especially in China. I think we are performing the highest number of PCI every year in the entire world. However, complex coronary artery disease, especially with patients with the impaired left ventricular ejection fraction rates, create a very high risk during the PCI. Balloon inflation causes ischemia, which reduces cardiac output, leading to the coronary hyperfusion and profound hypotension. MCS breaks this cycle by maintaining the systematic and coronary perfusion with this kind of supporting device, allowing the surgeons to perform longer procedures and achieve more complete revascularization, not just do it in a hurry or watching the monitor, from time to time. I think year 2026 is very important for the mechanical circulatory system. So let's check some updates. There are 3 main categories of mechanical circulatory system devices. IABP is our most familiar device. I think the most widely applied in our daily practice, and can help the diastolic pressure, but provides only about half a liter per minute during the PCI procedure. Impala, the microaxial flow pump, provides an active left ventricular support with flows up to 5.5 liters per minute. And the VA ECMO provides full cardiopulmonary bypass and 3 to 7 liters per minute, but requires both artery and venous access and higher anticoagulation. Each device has its distinct hemodynamic effects, insertion requirements, and complications. We just mentioned about this part. 4 major developments define 2026. First, CHIP BCS3, the first randomized trial of Impala versus standard care, was a negative with a signal of harm for cardiovascular death. Second, the STEMI DOOR2 unload trial was also negative. Third, the first hypophylactic VA ECMO randomized trial demonstrated feasibility. And fourth, new 2025 guidelines refine MCS recommendations. The bottom line is contemporary RCT evidence does not support routine, use of Impala in stable high-risk PCI, and a more selective approach is warranted. Second part, let's introduce some trials, for example, the CHIP BCS3 information. We know the PROTECT series spans 15 years. It's a series studies. PROTECT 1 was a 20-patient feasibility study showing safety. PROTECT 2 was an RCT versus IABP in 452 patients. And PROTECT 3 was a single-arm registry against historical controls, showing reduced MACE and less bleeding. And the PROTECT 4, the definitive RCT with over 1,200 patients and a 3-year follow-up, is expected to complete soon. PROTECT 2 enrolled high-risk patients with ejection fraction below 35% of 3-vessel disease. The primary 30-day endpoint was neutral. However, a post-hoc 90-day analysis showed a trend toward benefit, particularly in women and those with ejection fraction below 25%. PROTECT 3, while showing improved outcomes, was limited by its non-randomized design. The key message both suggested potential benefit, but were not so significantly different. Definitive answers were awaited for the following upcoming PROTECT 4 study. CHIP BCS3, published in the New England Journal of Medicine at the 2026 ACC, was the first randomized trial comparing Impala's CP with standard care, not in IABP, in elective high-risk PCI. It enrolled 300 patients across 29 UK centers with complex CAD and median ejection fraction of 27%. Technical success was excellent at 97%. This trial fundamentally challenges routine use of Impala for the stable patients. The results were disappointing. The primary endpoint using with ratio analysis showed no benefit, 36.6% versus 43%. More concerning is that cardiovascular death was significantly higher in the Impala, 26.7% versus 14.5%. The hazard ratio, 1.91. All-cause death mortality showed a trend towards harm. The accompanying New England Journal editor concluded that we should encourage a more selective approach for this kind of MCS machinery circulatory support use in high-risk PCI, particularly in the absence of overt hemodynamic compromises patients. And the STEMI DOOR2 unload trial presented at the 2026 ACC was also negative result. 527 anterior STEMI patients without shock were randomized to Impala placement with delayed perfusion versus immediate PCI. The rationale was that left ventricular unloading before reperfusion would reduce the infarct size. The result, no difference in infarct size, but ischemia time was prolonged by 47 minutes, and the bleeding and vascular complications were significantly higher. Routine Impala use before primary PCI in non-shock STEMI is not supported. So is there any role for Impella? A 2025 retrospective analysis from the UK database provides an counterpoint. Propensity score matched comparison showed that Impella had lower 30-day and 90-day mortality compared to ABP, 12.7 versus 16.6% and 15.2 versus 19.6%. The left ventricular ejection fraction recovery was also better. However, this was retrospective with inherent selection bias, and the comparison was Impella versus ABP, not standard care. These data suggested Impella may benefit in the sicker, heavier, more severe patients compared to ABP, but do not refute CHIP BCIS. I think 5 very key important information should be learned when we are using the Impella. Routine use in stable high-risk PCI is not supported by contemporary RCT evidence. Second, CHIP BCIS-3 showed a neutral primary endpoint with a potential cardiovascular death signal. Third, STEMI door-to unit was negative. Fourth, real-world evidence suggested benefit versus IBP in sicker patients, suggesting Impella should be reserved for these kind of hemodynamically compromised patients rather than the stable, high-risk anatomy, high anatomy risk patients. The last, I think the further studies will give us more detailed information. In the clinical use, for example, in this kind of very low ejection fraction patients with multi-vessel disease patients, I think this is relatively good to use. For example, this one with CTO-RCA and very large left ventricular ejection fraction is below 30. And using this kind of device, we can make the whole procedure very stable without any symptom, without changing the heartbeat or the heart failure symptom or any discomfort from the patient. Especially we at one time operate on 2 vessels, the RCA CTO and the LAD long diffuse calcification. And finally, we recanalize the circumflex, make full recanalization. The patient symptom are very stable. 3, the ECMO. Moving to the ECMO, I think this is also a very important device in our daily practice. This published on the JACC Advances in 2025 reported the first randomized control trial ECMO for complex high-risk PCI. This single-center study enrolled 70 patients with high syntax scores. The intervention was using ECMO at 2 liters per minute versus a control group with sheaths pre-placed and ECMO on standby. This landmark study demonstrated feasibility of a ECMO strategy. The largest Chinese experience comes from Xijing Hospital, I think, published in 2025. 220 patients refused the CABG, but the heart team were included with a median syntax score 34.7, very high syntax score patient, and a left ventricular of 36% on average. The 1-year all-cause mortality was 25.5%. The critical finding is operator experience matters a lot. Operators with more than 10 cases had a 44% reduction in 1-year mortality compared to those with 10 or fewer. 19.8 versus 31.5%, greater than the 10 cases appears to be the this kind of very important threshold. An ongoing multi-center RCT is comparing the standby versus this kind of ECMO strategies. 176 patients are being randomized to standby. This kind of high-risk patients with ECMO support, with full support from the start. Inclusion criteria include left ventricular ejection fraction below 35%, hemodynamic deterioration risk, last remaining vessel, unprotected vein, etc., with a syntax score 33 or above. Results are expected late 2026. The 2025 European revascularization this kind of resuscitation council guidelines states was a catheter lab ECPR may be considered as reduced. This kind of rescue therapy for selective refractory cardiac arrest patients. ECMO provides very immediate full cardiopulmonary support and can maintain the end organ perfusion during CPR, allows time to identify or to give more time and chance to solve the circulatory break of the patient. However, this requires an established ECMO program with rapid development capability. So once again, we emphasize that the experience of the surgeon is very important. So some key information when we are applying the ECMO. One thing is that evidence is accumulating from case reports to cohort studies to the first RCT through still with small sample sizes. Operator experience is critical, and ECMO has a clear role in peri-procedure arrest as a rescue therapy. The left ventricular afterload increase during VECMO remains a challenge. Combined strategies may be needed. For example, maybe combined use with IABP and other devices. Patient selection should focus on surgery, this kind of a risk with very low ejection fraction flow, last remaining vessel, unprotected vein, etc. This is a very young patient, 42 years of left main or cardiac shock. We can the left main is acute occluded with very young patient. And during the PCI, we can see that the RCA is maintained. However, there is no circulatory flow from the RCA to the left coronary artery. So with the help of ECMO and IBP, we recognize the left main, and the prognosis of this patient is very good. Next, let's move to the IBP, this kind of historical benchmark studies and contemporary use. BCIS-1 published in JAMA in 2022 was a landmark RCT established IBP as a comparator. 301 high-risk PCI patients with jeopardy score 8 and above, and the ejection fraction flow below 30% was randomized and involved in this trial. At 28 days, the MACE showed no difference. However, at 5 years, all-cause mortality was reduced by 34%, 28 versus 39%. This established that some patients without this kind of support will need rescue during the intervention. The IBP HFCS trial published in JCC 2025 enrolled 101 heart failure cardiac shock patients. The trial was terminated early with no significant difference at 6 days. IBP remains the lowest cost and the most widely available option in our daily practice for this kind of circulatory supporting system with simplest insertion. But does not provide very active flow. It's only supporting system, not an active flow to reduce the load of left ventricular. Current 2025 guidelines do not recommend routine use of IBP in cardiac shock patients. Its role is now limited to mechanical complications or as an adjunction. Let's give a quick glance through the 2025 to 2026 guidelines and the landscape. The 2021 ACC/AHA/ICAI guideline stables this kind of MCS may be the reasonable in selected high-risk patients as Class 2B recommendation. The 2018 EIC guideline is against routine IBP with no recommendation for preserved left ventricular ejection fraction function. And however, this kind of experience in the UK status and the evidence is limited. Use only under special situation. The 2024 EHJ open review proposed an algorithm combining anatomy, comorbidities, and clinical presentation to decide which kind of patient is most suitable for this kind of usage. Overall, guidelines are, I think, permissive but not committal. I think committal, reflecting the limited RCT evidence base. This kind of data, I think, will require more large randomized clinical trials for more, I think, information to get our daily practice. The ICI shock staging system ranges from A at risk through B, being, I think, C class, and D, the deteriorating. The 2024 APCS, I think this kind of consensus supports the MCS for the ICI stage C and D. And this kind of the principle is that match the MCS intensity to shock severity. Stage B may maybe warrant IBP if any, and the other kind of device, for example, ECMO or ECPR, and is more suitable for the very high risk patients, especially for the end organ perfusion is poor. The last one, patient selection and the future. Based on this kind of guideline and studies, I think for the patient with a high syntax score, Jeopardy score, left main disease, last remaining vessel, CTO complexity, and maybe the other patients, for example, low ejection fraction flow, renal function, COPD, and the other patients, for example, cardiac shock, I think is more suitable for this kind of MCS support. And next, I think 5 key questions still remains, even though we learn from this kind of studies and guidelines. I think who truly benefit from this kind of support system, which device is optional for different hemodynamic stages, and when should we start? For example, standby, I use it at the peri-procedure time or to rescue. How do we address the left ventricular afterload increase with ECMO? Do we need some combined strategies? And how do we achieve operator this kind of experience safely? I think 2 key trials are ongoing. The Protect 4 with over 1,200 patients and a 3-year follow-up, including ACS patients, will provide some definitive answer to the impeller versus standard care. And also, I think next generation devices on developing will solve some of the current problems, for example, the complications of these kind of devices, offering the, smaller pump and smaller caliber, higher flow, lower complications. Finally, there are some information, take-home information. For example, routine use of this kind of supporting system for the low-risk patients is not recommended. ECMO is feasible for specific high-risk populations. Evidence is ongoing but limited. ABP role continues to decline, not routinely recommended for the stable patients. And for patient selection should integrate anatomy, ejection fraction flow, hemodynamic system, and the team experience. Last one, some ongoing studies is going to offer new and more effective informations. Okay, I think this is all I want to show today. Thank you for your time.
Okay, thank you. Thank you, Professor Cao, for your informative presentation. Just now, you gave us overall updated evidence, IBP, ECMO, and impeller for elective high-risk PCS. Thank you. So next, it's my pleasure to welcome our next and the last speaker, Professor Zeng Yong from Beijing Anzhen Hospital. Professor Zeng is a very famous interventional cardiologist
in China. So he brings extensive clinical experience in managing cardiogenic shock and supporting high-risk PCI procedure in cath lab. So he will share his expert perspective on ECRS shock trial insights, ECMO in cardiogenic shock controversies, and patient selection strategies. So Professor Zheng, welcome.
Thank you, Professor Zhang. Thank you for your introduction. I just want to try you. Can you see my computer?
No, just your video, not PPT.
I just share. Just a minute. Okay, I'm sorry. I'm sorry. Oh, I'm sorry. Just
曾老师，他那个分享那个按钮，你可以从下边那个窗口，就是
是他那个什么系统不让我弄，是系统的问题。我已经打开隐私了。
但是曾老师确实是看不见。对，
是，他让我重启，糟糕，我应该试一下就好了。
没关系，不着急，你慢慢调试。
没关系，或者那个
发给谁？
对，曾老师，您可以发给你看看发给谁？发给我们后台，发给我们都行啊，我们来放一下也可以。
我发给。真是抱歉，我应该试一下哈。我能发给谁呢？现在？
看
李楠吧。
张老师，
曹老师，那实在我们先讨论呗。
对，要不然现在讨论一下，我马上就好。
OK，
okay. So now we can begin our discussion of this part. So from the above three speakers, they give us a series of information about mechanical circulatory support devices in cardiogenic shock and elective high-risk PCI. So I think I will start by sharing my thoughts first. From the above speaker, we know that ECMO nearly triple the vascular complications, and more than double the moderate to severe bleeding. But as we all know, recent mediation analysis from these trials found these complications are actually not the leading cause of mortality we see in the ECMO group. So I think if the complications are not the explanation, what is it? It is the physiological downside of ECMO itself. For example, the elevated left ventricular afterloads caused by retrograde aortic flow. We know that this will offset any peri-procedure hemodynamic benefit it provides. And if this hypothesis holds true, should we be shift our clinical practice entirely? For example, instead of writing off mechanical circulatory support altogether, should we be rethinking upfront left ventricular loading strategies like Impella as a standard part of our support protocol? So, in my opinion, the support strategies should not be deeply individualized, but not rely on any current RCT data. So here, I also would like to hear what the other professors think about this problem.
Can you see my slide? I'm sorry.
Oh, okay.
Can see my slide?
Yes.
Yes.
We can see your TV.
Okay, I'm sorry for my fault. Thank you, Dr. Cao and Professor Zhang, and good afternoon, respected chairs and dear colleagues. I'm Zheng Yong from Anzheng Hospital. It is great honor to share our insights at the 2026 AHS Research Summit. Today, my presentation is titled Insights from the Echo Shock Trial, Controversies and Patient Selection for VA ECMO in ACS-related cardiogenic shock. And against the background of several negative landmarks, RCT on mechanical circulatory support in cardiogenic shock, we will first review key trial results and current clinical controversies, and then we will integrate the domestic guidelines recommendation and real-world clinical experience in China to discuss how to appropriate select suitable patients for VA ECMO and other circulatory assisted devices for patients with acute coronary syndrome complicated by cardiogenic shock. And although there is insufficient evidence that extracorporeal left support echoes reduce mortality, but its use in cardiogenic shock caused by myocardial infarction has been increased. This is a the echo shock is a multi-center study that enrolled patients with acute myocardial infarction and the cardiogenic shock who required early revascularization. Patients were randomized assigned to two groups. The echoes group received early echoes plus standard medical therapy, where the control group received standard medical therapy alone. The primary outcome was all-cause mortality within 30 days. Safety outcomes included bleeding, stroke, and limb vascular complications requiring interventional or surgical treatment. Well, this trial, a total of 420 patients were randomly assigned, and 417 patients were included in the final analysis. And at 30 days, all-cause mortality was about 48% in echo group compared to about 49% in the control group. The rate of safety events, including moderate or severe bleeding, was about 23% in echoes group and 9.6% in the control group. The rate of peripheral vascular complication requiring intervention rate was 11% and 3.8% respectively. So this trial make a conclusion among patients with acute myocardial infarction and cardiogenic shock scheduled for early revascularization. Echoes extracorporeal life support did not reduce the risk of all-cause mortality within 30 days compared with standard medical therapy alone. Where this trial, cardiogenic shock was defined as systolic blood pressure of less than 90 millimeter mercury and arterial lactate level of more than 3 millimole and signs of impaired organ perfusion. This is a study flowchart for intervention to treat analysis. From June 2019 through November 2022, a total of 877 patients were screened at 44 centers in Germany and Slovenia, and at last a total of 417 patients were ultimately enrolled in the trial. How about the baseline? The baseline characteristics were well balanced between the treatment group, and the mean age was 63 years with a predominance of men, and 2/3 of the patients presented with ST segment elevation myocardial infarction, and the left anterior descending artery was the most common infected related artery, and also approximately 2/3 of the patients had multivessel artery disease. Most important, overall, 77.7% of patients underwent CPR before randomization. Where notably, a small portion of patients in the control group also received ECMO, and the rate of left ventricular unloading, including IBP and Impella, was very high in the control group. The death, the primary outcome, the death from any cause at 30 days, was similar in the two groups. Pre-specified and post-hoc analysis showed that the results across all subgroups were consistent with the primary analysis. For example, subgroup including sex, age, diabetes, and type of infection, etc. The echo shock trial showed that routine early extracorporeal life support provided no survival benefit and caused more procedural complications compared with standard therapy with selective IBP or Impella use. And echoes should be recommended only as a salvage treatment for refractory shock, rather than as upfront routine support in unselected patients. And the low rate of left ventricular loading and the high proportion of post-cardiac arrest enrollment may have limited the potential benefit of ECMO. And further stratified trials, I think we need to identify suitable candidates and optimize support strategies. And this trial clearly demonstrates that a routine prophylactic implantation of ECMO should not be recommended for all patients with infarct-related cardiogenic shock. And the empiric and widespread of use ECMO based on previous strategy studies need to be reconsidered. And this conclusion should not be misinterpreted as evidence that ECMO is completely ineffective for cardiogenic shock. And ECMO remains a vital rescue circulatory support modality for patients with refractory shock. And careful patient selection is necessary to identify potential beneficiaries. Patients with prolonged, for example, patients with prolonged cardiopulmonary resuscitation, irreversible brain injury, or severe peripheral vascular disease should be excluded. And individualized ECMO initiation may be considered for patients with SCAI stage D or E or higher shock without severe post-arrest brain injury. And whether left ventricular unloading can improve outcomes in patients receiving ECMO remains unclear. The extremely low utilization rate of left ventricular unloading devices in ECHO's group may be a critical confounding factor explaining the neutral survival outcome. The previous 3 RCTs on ECMO all showed negative results, whereas the danger shock trial using Impella reported positive outcomes. Why did this powerful support device fail to improve survival in patients with myocardial infarction and cardiogenic shock? First, I think we should not note that these RCTs differed substantially in their enrolled patient population and with a high treatment crossover rates. This does not mean that we should abandon ECMO. Instead, we need to apply it selectively as a precise targeted therapy. So, which patient can truly benefit from ECMO? Beyond ECMO, what other treatment options are available? Well, in summary, the IBP SHOCK 2 trial showed no reduction in 30 days mortality among patients with stage C or higher cardiogenic shock, and the ECHOS SHOCK trial found that early ECHOS therapy failed to reduce 30 days mortality and was associated with more complication. These findings may lead clinicians to discontinue the routine use of these devices in daily practice. In contrast, only the Impella trial achieved positive outcomes with reduced all-cause mortality at 6 months. Therefore, Impella appears to be a better treatment option in patients with myocardial infarction complicated with cardiogenic shock. And based on the result of the PULSE trial, the novel mechanical circulatory support device AVAC 2 liter can provide significant left ventricular unloading in patients undergoing high-risk percutaneous coronary intervention. This is the case using the AVAC to support with successful revascularization to complete LAD and LCX intervention segment, and the vital signs remained stable, and the AVAC removed, and with successful femoral artery closure, the patient returned to the ward safely. And next, we will discuss guidelines evidence and real-world clinical practice in China, where neither ACC nor ESC guidelines recommended the routine use of ECMO or IABP. However, temporary life support may be considered as a bridge to surgery. In Asia, especially in China, the mortality rate of myocardial infarction continues to rise year by year. The burden of cardiovascular disease remains heavy in both rural and urban areas. And in China, with the development of chest pain centers and emergency green channels for myocardial infarction, the diagnosis and the treatment of critical ill patients have greatly improved. Chinese guidelines provide relatively positive recommendations for IABP, although strong RCT evidence is lacking. Clinical practice indicates that timely IABP use help stabilize overall circulation. As for ECMO, it is an advanced support tool used in well-equipped Chinese hospitals. ECMO alone has some limitations. It increases left ventricular offload and does not directly improve coronary perfusion. So in clinical practice, we usually combine ECMO with IBP to address these limitations. To summarize current clinical practice in China, primary hospitals mainly rely on IBP for emergency support, whereas hospitals with established ECMO team use ECMO plus IBP for critically ill patients. And this approach aligns with medical resource conditions in China, and I think maybe also in to the other Asian regions. So how about axial flow pumps? I think Dr. Cao had talked about a lot of it. This type of device can directly increase cardiac output, blood pressure, and peripheral tissue perfusion. Such devices are already available clinical use in China, and several domestic versions are now undergoing clinical trials. It should be noted that existing studies have not yet confirmed clear survival benefits in critically ill AMI patients. Even so, Chinese guidelines give a class 1 recommendation for this device because its circulatory support effect is reliable in real-world clinician practice. When choosing this tool, we must keep one complication in mind: hemolysis caused by red blood cell damage. And conclusion, finding from the ECHO's shock trial shows that routine early VA ECMO fails to reduce 30 days mortality in AMI-related cardiogenic shock, but increases the risk of bleeding and vascular complications, highlighting the need for individualized device selection rather than universal use. And timely IBP in hemodynamically unstable patients may offset the hemodynamic drawbacks of ECMO, and axial flow pumps and novel pulsatile devices such as further diversify precise circulatory support strategy for high-risk cases. And that's all what I share. Thank you very much. Thank you for attention.
Okay, thank you, Professor. In my opinion, although the data of ECS shock trial is negative, but in my opinion, the most important thing is for us is to figure out exactly which patients will actually be benefit from the ECMO and when is the best time to study it. So, Professor Cao, whether we have enough time for discussion.
I think all the speech is wonderful. I noticed that Professor Yao Qiheng is online. Professor Yao, is there anything that you want to share? I'll give some comments about today's topic.
Thank you, Professor Cao, and all the excellent speakers. I learned a lot from the lectures. I think at the moment, evidence is not very clear that these supporting maneuvers, IBP, ECMO, or impeller, is beneficial to every single patient. However, I believe that we haven't really found the sweet spot that is the real or the exact patients that would benefit from this prophylactic protective device. Because as interventionists, like everyone else here, we really don't want to see a shock patients in the middle of a procedure. Sudden ventricular fibrillations, drop in BP. So what these maneuvers are trying to prevent these catastrophic hemodynamic situations occur during high-risk procedures. So I think, as mentioned by several of the speakers, there are a lot of considerations, not only the patient's demographics, but the anatomical severity of the disease and the difficulty of the procedures. I think that is also important, whether it's calcified tertius or, you expect there could be difficulty. I think these are all combination factors that really would help us to guide which patients we should prophylactically put this device in. But anyway, I know time is limited. Just a short comment for everyone. Thank you for the invitations, and I learned a lot from all the experts. Thank you.
Thank you, Professor Yao. Professor Devas, is there anything that you want to share and maybe give us the honor to close the session? Thank you.
Yeah, thank you. Thank you very much. Across today's presentation, actually, one common theme has emerged. It's timing, patient selection, and device choice. If you could change only one aspect of current practice worldwide to improve outcome in cardiogenic shock, what would it be? For me, it's timing. We already have excellent devices. Our greatest challenge is not technology, but recognizing the right patient early enough to use that technology effectively. From my perspective, the greatest opportunity is building regional shock networks that enable early diagnosis, timely transfer, and rapid access to appropriate mechanical circulatory support if needed. Maybe starting the whole thing from China, I hope. Even the most advanced device cannot compensate for delayed transferal, as you know. This is the whole thing that I want to talk actually about what I heard from the nice presentation and outstanding lectures that I hear. Yeah. If you ask me about the situation in Jordan, our approach actually follows the current international guidelines while adapting to our local resources. Primary PCI remains our first line perfusion strategy whenever feasible for patients with cardiogenic shock. We emphasize early recognition, rapid revascularization, multidisciplinary heart team decision making, and prompt hemodynamic stabilization. Mechanical support is considered selectively. In appropriate patients, we currently use intra-aortic balloon and ECMO in selected centers, while access to Impella is still limited. Therefore, careful patient selection and timely transferal are particularly important in our Jordanian practice. Yeah. This is the whole thing. And thank you all, actually, for this interesting and informative speech from all our lecturers and all our moderators. And thank you to all of them and all of you, and especially those who are with us hearing and sharing this session. Thank you.
Okay, thank you. I think we are good to
Dear
close the
colleague,
session. Thank you all online.
dear friends, as the president